Please, we are going to start in a few minutes. Thank you. Once again, dear colleagues, good morning. Welcome to the first morning session of the second day of the 34th Annual Congress of the European College of Gerodontology. Together with my colleague, Associate Professor Sanja Peršić-Krišić from the Department of Removable Prosthodontics from the University of Zagreb School of Dental Medicine, me, Ljiljana Đukić, Assistant Professor from the Pharmacology and Dentistry from the University of Belgrade School of Dental Medicine, we will moderate this session. Our estimated speakers today are going to share with us their experience and their knowledge regarding several topics, including innovative methods in prosthetic rehabilitation of older people, also significance of the health services research in the aging society, and the characteristics of restorative and endodontics treatment in older dental patients. It is my honor to introduce to you your well-known Congress chair as a first speaker this morning, Professor Aleksandra Popovac. Professor Popovac is assistant professor at the Department of Prosthodontics, School of Dental Medicine, University of Belgrade. She's dedicated her professional life in teaching, in lecturing our students in scientific and clinical work in the areas such as gerodontology, removable prosthodontics, as well as education of dental care sciences. Her main goals are the promotion of gerodontology, as well as creating a strong network between dedicated dental professionals with one goal: to treat adequately older patients. She is also currently a president of the board of the European College of Gerodontology. Without further ado, I'm asking our Congress Chair, Aleksandra Popovac, to present us her lecture.
Thank you, Ljiljana. Dear colleagues, dear friends, thank you for being here this morning. For the beginning of our second day, we have a little bit of prosthodontics. And although my topic is about contemporary materials for telescopic dentures, my story must start with subtotal edentalism, because it is one of the key points of prosthodontic aspect of gerodontology. We all know that edentalism is decreasing. From this data from 2005, where we can see that some prevalence was pretty high in some countries, we have decreased in 2020, when it is estimated that the edentalism prevalence is around 20–24% worldwide. That is due to advances and progress in oral disease prevention, as well as in restorative dentistry. And although these numbers may vary a lot between countries, it is obvious that older people nowadays tend to keep more their natural teeth comparing to a few decades ago. But what does it bring us? It may bring certainly more prevalence of partial edentalism, but also sometimes, and I may say often, complicated situations like this, when it is really hard to decide what treatment option should we offer to patient, and what teeth to keep and what to extract. Usually there are two approaches when deciding what to do with the few remaining teeth. One approach is to just extract all and to make edentalism, which is something that even our patients often offer to us. to make the situation more simple. The other approach is to just keep strategically important teeth and then to have more prosthodontic options. Subtotal edentalism we can define as 1 to 4 remaining teeth which we can use now for our prosthodontic, for our dentures. Usually these teeth need some pre-prosthetic preparation, some endodontics because they have inclination, extrusion, wear, caries. But despite all this preparation that can be difficult to our older patients, we think that these teeth are precious. They're precious because they can maintain periodontal chewing reflex. They're important from psychological point of view for the patient, and we certainly have more options to offer to them. But the next question is, what is optimal solution for our older patients? They usually don't refuse removable dentures. They consider it, but they ask for some comfort solution, for some chewing efficiency, and we must think about these kind of solutions and also for prophylactic effect of these dentures. We can offer conventional removable partial denture, but our patients often have negative experience with clasps, mainly, and they also can make some complications, especially when we have xerostomia, which we listened about yesterday with Professor Anna Pucar, and then we have more chances to get caries in these teeth in cases of xerostomia. Then bars are a very good option, but we need to have teeth in favorable position, and we must think about dimensions of these constructions because they can be rather high in occlusal gingival dimension. Here we do a lot of these ball attachments, intraradicular types, because they are cheap. But also sometimes it is hard to achieve optimal retention. And also they have sometimes problems with space for artificial teeth. And last but not the least, Her Majesty telescopic denture. Telescopic crowns are one type of double crowns, with the primary crown cemented on the abutment teeth and the secondary crown rigidly connected to denture framework. This telescopic system means cylindrical constitution, and that the gingival and occlusal circumferences are the same. This type of double crowns really offer many advantages compared to other type of attachments. Cross-arch stabilization, we are sure of axial loading of our abutment teeth and therefore prophylactic effect. Optimal retention force, if that is achieved, the patient has a comfort and self-confidence and also consequently good masticatory efficiency. But nowadays, I may say in the last 2 decades, these conventional telescopic dentures are mainly repressed from our everyday clinical practice. It is mainly due to a high price, and consequently, dental technicians don't have a lot of chance to do them and don't have experience. So it is all some kind of negative circle of avoidance. But why high price? Because decades of use have proven that gold alloys are the best solution for this type of dentures, for this type of double crowns. And we know that the price of the gold alloys. So we had to seek for some alternatives. And the help came in digital protocol development and materials that can be milled. So nowadays we use non-precious alloys, but milled titania, zirconia, and polyethylated keton. But also this type of combination of materials are not present in practice as they should be. Because we wonder what type of combination is the best. And the really big question, what about retention force in these combinations? We know that retention force should be, it is optimal between 5 and 9 or 10 newtons. And a lot of patient satisfaction depends on the retention force, because if it is too strong, it may negatively affect the periodontal tissue of abutment teeth. And if it is too weak, we see that in 2010, Bayer and Associates concluded that if the retention force is lower than 2.5 newtons, we may consider that denture non-functional. It is not functioning for patients. And my personal journey with telescopic crowns started with this publication from 2009, when together with Professor Stančić, we published our study where we measured manually separation force of 50 telescopic constitutions made from gold alloy, standard procedure. And although the procedure was really standard, we found optimal force in only 50% of cases. So it is not predictable. And we concluded that it must be due to errors in the processing and casting. And also, beside the intensity of retention force, also really important question is, how does retention force change over time? We have something called settling in phase. That is the time during which these surfaces that are in the contact suffer wear. And at the end of this settling in phase, we consider that they have achieved final geometrical form. But what about these other materials? For dozens of publications, I choose most important conclusions. From the study conducted in our dental school, we concluded that favorable combinations are zirconia and zirconia with electroplated gold and zirconia with PEEK, that they achieve optimal retention force and that the settling in phase is finished after 900 cycles approximately. However, Schimmel and authors, associates, they recommended different type of combinations. They recommended non-precious alloys, milled, and titanium and PEEK. However, their retention forces at the beginning, initial ones, were even higher than 30 newtons. Also, Luft and Associates concluded that different combination of materials differ in retention force, of course, and that we get more predictable results with milled materials, which we, of course, agree. And in our search for affordable alternative for gold, we chose polyoxymethylene. It is not unknown material in dental practice. It is thermoplastic polymer from the acetal group. It can come in two formulas, homopolymer and copolymer. And this copolymer means additional methylene groups, which result in better thermal and hydrolytic stability and also better resistance towards polymer chain degradation. We now know that positive characteristics of these materials, is good polishing properties, possibility of coloring, that has good chemical stability, mechanical resistance, and it is slightly flexible. But some authors consider it as positive characteristic and others as negative one. We also found from literature that staining is one of the negative characteristics. And also we noticed that, of course, some parts of denture framework have larger dimensions due to differences in material, but there is no clinical data how can it affect the abutment teeth. So far, we know application of this material. It is for conventional removable partial denture with clasps. Also with attachments, I've got this from one patient, not my patient, but you can see the staining after 1 year of use. And convenient clinical application for older adults is also like overdenture, When we have a few leftover teeth with severe wear, but without active inflammation and pain and discomfort. But there was simply no clinical data about telescopic denture. And we choose it precisely for that, because we thought that the combination of mechanical resistance and the flexibility is good when it is expected intimate contact between primary and secondary crown, and also we expect denture to settle during function. But first we had to see what the retention force is. Is it optimal? We used the same instrument, a manual dynamometer. We made several polyoxymethylene frameworks with the secondary crowns with 3 or 4 abutment teeth, and for primary crowns we choose non-precious alloy milled cobalt chromium because of the precision and because of the price. And we measured both individual and total retention force. We got statistically significant lower forces compared to gold alloy 15 years ago. But at the end, they're optimal in the sense of total retention force, so we could proceed with the clinical phase. Also, it is interesting that although we didn't simulate the whole settling in phase, but after 100 separation cycles, the retention force almost didn't change at all. We haven't the same results or just slightly lower. I won't bother you with the details of our clinical study, just that we chose, of course, geriatric patients without diagnosed craniomandibular dysfunction, without dementia, with 2 or 3 remaining teeth, no matter upper or lower jaw. And what we wanted to find out? We wanted to find out overall satisfaction. Does it work in clinical practice for them? What do they feel about it? We wanted to clinically assess retention force, and we wanted to see denture appearance. So far, 19 patients are enrolled in the study, but only 11 of them finished the second stage follow-up. We unfortunately had 1 dropout, and you will see preliminary results of our first 10 patients. Involuntarily, we had in these first 10 patients half of dentures in upper jaw and half of them in lower jaw. I will just really briefly introduce you with the most important clinical and laboratory phases. Conventional grinding, impression. Of course, this part can be digital. We can scan the grinded teeth and make a virtual model, but in this case, we went with the analog protocol. We made this plaster cast, we scanned it, and in ExoCAD designed and milled primary crowns. We tried primary crowns in the mouth, and if everything is okay, we proceed with the second impression for the framework. This is the master cast with primary crowns. Next few phases are really conventional one, wax rim production, then interjaw relation, of course, in the patient mouth, clinically, determination, and then position of artificial teeth, trying in the mouth, and if everything is okay, we proceed with the final laboratory stages, which will result in making polyoxymethylene part of denture and parts from acrylic resin. We double the master model. We also make a silicone key with this artificial teeth. Technician make a future model for denture framework. And now continue with the flask. The final stage is technique injection molding. Polyoxymethylene is thermoplastic material. We have to heat this. It goes in a thermopress machine. And when we finish the process, open the flask, this is what we get. Now technician is proceeding with processing. These holes are for mechanical retention with acrylic resin. We put back the silicone key for acrylic parts. And this is the final product. We can proceed with denture delivery. as you know, or you may not know, we have to deliver it all together. We cement the primary crowns, usually with glass ionomer cement, but we have to deliver it all together. And the first separation is between 2 hours after delivery and 24 hours. This is the photo just right after delivery. And then we proceed with a clinical assessment of retention force. Both clinician and patient assess the retention force. We have a first blue one on the day of delivery. Second is after 3 months, and this green one is after 6 months. This is dental medical doctor, so clinician estimation with the Likert scale. So you can see that from 1 to 10, they assess it way better than results we got from our laboratory phase. And also that almost the same or even higher retention force after 3 and 6 months. And now the patients, what do you think? Did the patients assess it better or worse than clinicians? Better, of course. They assessed it like it was really strong, and also that it haven't changed. We discussed about these results, and we think that it is a difference between just separation force from the instrument and the real retention force because of denture flexibility, that it cannot be assessed in the instrument. So because of flexibility, it gets better in the patient mouth, and that's why we got these results. And indeed, just see our dear patient Bosa. You can see how she struggles a little bit to separate it, but she's really satisfied with retention and stabilization, and she's well trained. This is after 3 months. So she doesn't have problems overall, and she's really satisfied, yes. And about overall satisfaction, we chose Geriatric Oral Health Assessment Index because it was created for geriatric population. It is designed to assess 3 aspects of oral health-related quality of life: pain and discomfort, psychological aspect, and oral functioning. Overall, we had improvement in oral health-related quality of life, but in one patient, in one patient, yes, we had a decrease, and we have a patient with just really not significant improvement. In these patients, we had conventional complete denture, lower denture, so conventional complete lower denture, and we cannot instantly blame that denture, but we saw these patients regularly, and they were always complaining about these lower dentures, not about telescopic one, but of course they see the treatment as one whole, so they didn't get improvement in their quality of life because of that lower denture. Regarding denture appearance, we didn't get staining so far. So we discussed it with our technicians, and they said that it is a lot up to them, because if they proceed with the protocol recommended by manufacturer, we don't have staining. So we had good technicians, they haven't had staining so far, but you will see later one exception. Of course, complications, we had it, we expected it. We had 2 minors and 1 major. 2 minors were about artificial teeth, 1 fracture and 1 fallout. But the reality is that we get also these kind of complications with our conventional telescopic dentures and conventional removable partial denture with clasps. The same day when this patient from study came, my old patient with conventional telescopic denture with gold has also experienced the same type of complications, so we deal with that, we expected. And we had 1 major complication. This is a 73-year-old male patient. We had this after 2 weeks, complete separation of front part from the denture framework. After 3 months, You can see cracks, you can see stains, you can see difference comparing to other patients. And after 6 months, we got this. This denture tells a lot of stories. Stories about oral hygiene, about smoking, about intention to repair it himself. He tried it with different materials. And after a lot of talking with that patient, we got eventually, after all this time, we got this. I clench my teeth when I'm nervous, when I'm busy, when I'm working. And after that also I have a pain muscle when I wake up in the morning. Of course, we didn't get these answers at the beginning. We specifically asked about this, and he denied everything, and after 6 months he admitted that he had this kind of problems. So perifunctions daily and night, bruxism. We learned it harder way. You can see these teeth, lower teeth, but wear is not something that is that we don't expect in older people. We see this all the time, and that's not the evidence that every patient like this has bruxism. And we have many publications that the difference in mastication force when we had dentures and when we had natural teeth. But as our dear Professor Müller in one of her papers stated, that there is still a lot to learn about this mastication force in geriatric patients. It is not all about dentures, denture stability, or occlusal morphology. We had other patients with natural teeth in the antagonistic jaw. In these patients, we even restored it with metal ceramic crowns, but he didn't suffer that kind of complication as the patient from before. And at the end, what should be our next step? Definitely to keep natural teeth, but to include more implants. And because we can't connect them rigidly, the perfect solution would be a removable bridge. So with this system, Revocon, we can do this. We expect it to come soon here. And it can even, retention force can be adjustable. So as recommendations, definitely think about keeping a few strategically important teeth for older patients. Also consider multiple solutions. Don't forget about telescopic denture. Telescopic denture is back. Try with new materials, combination of bill materials. Consider polyoxymethylene as affordable solution, affordable alternative. And preliminary, we can say that this material can achieve optimal retention force during a long period, and that the level of complications is similar or the same as in conventional dentures. Of course, be aware of perifunctions, bruxism, but we should be aware of that in any case, in any prosthodontic solution, and in any age group, because it is a problem in every kind of prosthodontic treatment. Of course, this study won't be possible without our colleagues from Dental Laboratory, 11K, Petar and Dimitrie, who really share our enthusiasm for science and for results, and we often discuss some situations, so it's really good to have them in our team. Thank you for your attention.
Professor Popovac, thank you for your very informative lecture. We have time for a short discussion, and I will ask my colleague, Professor Persic, to ask your question.
Thank you, Alexandra, Professor Popovac, for a very nice lecture. I have one question to ask. What do you think, what is the future of this material?
When we discuss it, we really still see it as the future for more for telescopic dentures than to other. Maybe to overdentures, yes, like a good solution, but we consider it better for telescopic dentures compared to denture with clasp because of this different type of attachment with the abutment teeth. It is better to have it over the primary crown than just with the clasp. We think that this may, but of course we must wait for the results for also for our control group for statistic comparison, but from our clinical experience and from patients' comments, it really is something comfortable to them, and of course to choose wisely which patient to talk with them, because often we hear, I don't want clasps, and there is 2 teeth. What should we do? Okay, there are other options. There is a bar, there is I don't know, 5 or 6 solutions, but and every solution has its disadvantages. Nothing is ideal, but it is one of the options.
Okay. I don't know if you have mentioned it, but for how many years are you using this material?
It's not years, it's still a 6 months follow-up, but we plan to continue follow-up at least 1 year, and then we will see the...
Thank you.
Thank you.
Thank you. I also have a question. What is the effect of polyoxymethylene on periodontal tissue? Because you use this material for telescopic crown, and it have a close relationship with these tissues.
Yes, I didn't have time to show everything. We measured with CPITN index, and so far the same. Okay, we had to periodontally, we had to do a periodontal treatment before study start, but so far the index is the same. So it depends on a patient. If it was 1, it is still 1. Maybe in one case we have increasement of the value. So far so good, but we will see about that.
Okay, yes, you're planning to further investigate this. Is there any questions from the audience? If not, Professor Popovac, thank you very much.
Thank you.
Dear colleagues, I have the honor to present you our next speaker, Professor Barbara Jansen. She is a professor at the Ghent University. She is a well-established researcher, published numerous research papers, several book chapters. She recently was guest editor for a special issue of Gerodontology journal. Her research interest lies in an improvement of the oral care in institutionalized care, improvement of the oral care in the home-dwelling older patients, and explaining or pointing out the significance of interprofessional collaboration. Also, she is investigating the relationship between oral diseases and systemic diseases. Through her career, she is also very active in several organizations, including ECG, also European Association of Public Dental Health, great research consortium at Ghent University, as well as Belgium and Dutch research consortium for oral care in older patients. It is my great pleasure to hand the microphone to the professor.
Good morning, everyone. I saw some people running out. Maybe that's because I'm not going to show you any teeth during my presentation. And it might be a bit challenging to some of you. So I hope to still be able to entertain you a little bit because I'm going to talk to you about health services research in an aging society. And as our dear colleague said in her introduction, the inspiration comes from the special issue I edited in Gerodontology that came out in March, for some of you that might have had a look at it. And the topic was exactly that. For those that are inspired after my lecture, there is a very nice book from Springer that came out last year, and on the top, to introduce you to the topic. It's a very nice and easy read, and at university sometimes you can just download the ebook for free if you're on the library. I didn't have to buy it anyway. Just to introduce the topic, I want to take one of the papers from the special issue that was a systematic review looking very broadly at any oral health intervention trying to improve oral health independent older adults. And the results are quite shocking. They found only 30 papers. And the outcomes were rather clinical. It was about oral hygiene, for example, very little evidence on long-term effects. And there was not a single paper looking at changes in the use of the oral health care system. Now, why is that? First of all, it's challenging doing research in our population. But I think the main thing here is that they looked only at RCTs. And we need not only more research, but I think we also need different research. And we need to step a little bit away from that very clinical controlled environment of the RCTs if we want to progress in gerodontology. And one of those things that you could do is health services research. Now, what is health services research? Because I think many in the room, I mean, the name says something, but don't have exactly a clue what it means. So it is about organizing care, delivering care. It's about outcomes of healthcare systems at an individual, but also at the population level. It's not only looking at the system, but it also includes interventions, trying to change the system and then see what is happening. And in general, you will have several disciplines involved. You won't be able to do it alone with the people from the dental school and together with some medics. You will need to collaborate with epidemiologists, people from the social sciences, public health people, etc. You will do this research empirically within real healthcare settings, or you will do it based on data from those settings. Typical example are the claims data that exist in many countries. It will, in general, focus on real-world healthcare practice. So we won't create this very controlled setting for our research. We will look at what is happening in real-world practice, and it is driven by perceived or anticipated problems, and the typical one is the upcoming aging society. This is something that drives health services research because we know what is coming up, we know the challenges that we will receive in the future, and it typically also responds to the needs of policymakers and stakeholders because they have questions for us. And who else would they address than the dental field if it's related to oral health? But we very often don't have the answers because we are in general not doing a lot of research on the topic. It will be centered around the values, the needs, the interests of the potential end users. So it's not only about dentists, it's also about other professions, it's also about the person receiving the care in the dental chair or not receiving it and not having access. So you, by nature, end up with studies around affordability, access, safety of care, efficiency, how we collaborate together, for example. And it will take a broader societal perspective rather than a very individualistic perspective. And you can, it will both look at determinants of the system as well as outcomes, and they can be very broad. So at the level of the outcomes, for example, you would go way beyond oral health. You would look at quality of life, you would look at efficiency, at safety, utilization of care, and the determinants will also go further than just the financial issues, for example. You would look at education, the financing system, social capital, social networks, how that relates to access to care, for example. Why is this so important in gerodontology health services research? We all know that we live in an aging society, and many countries will have a very strong transition, a demographic transition. But at the level of oral health, this goes alongside a very sharp transition in oral status. In some countries, it's a bit different, but at least in many countries in Central Europe, we see a very steep decline in dentulousness. People take their natural teeth up into old age, but those natural teeth don't look as the natural teeth of the younger generations. They are full of complex restorations. It's a major challenge just to maintain teeth as they are, because they're so difficult to clean with all these massive crowns and bridges and things that are made very aesthetically but are impossible to clean with interdental brushes, for example. People don't only get old, healthy aging, they get comorbidities, which makes them part of a high-risk profile for new diseases. And we have cleavage inequalities. We don't just have inequalities if we look within the older population and we compare nursing home residents with the home-dwelling elderly. We have cleavage inequalities on many fronts. Access to care, they completely depend on others. They have a very different oral health than the home-dwelling elderly. If I take the transition in one specific topic, this is a nice paper from Schwedeke, who made a simulation based on the German data on the periodontal needs of our population. And he made a simulation up to the year 2030, which is not far away. And he looked at the data from the end of the 90s and then looked at the national data, saw how it progressed, and then made a transition up to 2030. And we can see very nicely where the peak in periodontal needs and prevalence was traditionally between 30 and 50 years old. By 2030, it will be around 80, 90 years old. So an extreme transition in a very little amount of time. And also if you look at the number of teeth that will need periodontal treatment, it goes up. So we as clinicians, we can rapidly be confronted with a very different kind of patient in our clinic. And we will have to adapt our services to it. We have high unmet needs for dental care. If you look at the graph and you compare unmet needs in medical care, pharmaceutical care, and dental care stands out in many countries. And the systems and how they cover the populations, they differ enormously in Europe at the level of the population, the affordability, the kind of services that are covered. So there's many different systems, and we really don't have a clue what the best system is to approach as many people as we can in an affordable way. And it won't be the same system in every country, of course, because the context matters. But there's still a lot of unknown stuff. People don't have the same access, even within one country. These are data from the TILDA study, which is a very nice aging study in Ireland. And you see that people living in rural environments have less access to dental care compared to people living in the capital city, for example. People, depending on their oral status, will go less or more to a dentist. Typically, people without natural teeth in the mouth, they stop going to the dentist. For awareness among the old adults, whether it's necessary to go to the dentist. And when we ask them for their reasons why they go to the dentist, typically people without any teeth in the mouth will say, I cannot get here, or I cannot afford this. Whereas people with natural teeth in the mouth, they will give you different reasons why they don't access them. And we have very little knowledge on what people actually want when they get older and of dental care. This is a very nice systematic review that was published this year that looked at what are the needs and the priorities of older people in our society at the level of health care. There were 75 papers in there, but only 3 mentioned oral health. So there's a considerable knowledge gap. Now, this systematic review was published now in 2024, but looked at papers up to 2022 or something, and there have been some publications in the last 2-3 years, so we have some added knowledge now. But there's really a big knowledge gap, and when we look at those few papers, they ask for more information on how to maintain their teeth. They want research on access to care. They want research on workforce training, how other healthcare workers can address oral health as well, how they can better collaborate, for example. Where does this take us in health services research, all those things that I just mentioned? I think we will have to start earlier in life. We cannot wait until people are care dependent to start organizing it differently. We cannot lose them along the way. It will depend on public health action. We need to step away from the individual victim blaming because the system decides a lot for people that live in it. We will have to integrate our oral health promotion into the bigger picture of NCD prevention. We will have to address the many barriers people perceive when accessing care, and those barriers are different in different settings. We will have to collaborate with other healthcare professionals, but not only healthcare professionals, also social care workers are so important. And I'm convinced that it's unavoidable that e-health will play a role in connecting us all as healthcare professionals, in transferring data, in having better access on how system works, and also at an individual level for the oral health of people. There are different perspectives that you can take when you do health services research. The first one, as you saw before in the paper that is under-addressed up to now, is to look at the perspectives of the end users. And there have been some really nice papers in the last 2 years looking at people's preferences. How would they like to see their care addressed? And when you read the nice paper of Najla, for example, where you compare different countries, Anastasia was also part of it, you see that different countries have different views on how they would like to see their dental care organized. We are very little aware of how those people grew up. This is a quote from an older person in a study that we are performing at this moment, saying that when I was young, a toothbrush was like a Rolls Royce for a laborer. This was something precious that not everyone had. Not many people grew up with a toothbrush. So they're little aware of the importance of it. Yes.
Okay, I have a loud voice, so I hope up to now you understood me, and I'll keep the microphone far away. I don't even notice when the microphone is on or not, and no one said anything. And I see him standing there. I said, why is he there trying to tell me something? And I know how difficult it is to interrupt me when I'm talking, so I'm sorry. There's another way of looking in healthcare services research, and that's the view of the healthcare providers, because you can organize a system that is ideal for the older person, but if no dentist agrees to work in that system, then, I mean, it's designed for nothing. And there have been some very nice publications on experiences of dentists working, for example, in mobile care settings, participating in alternative services. There have been many papers, several systematic reviews looking at barriers perceived by nurses, aides in nursing homes trying to provide dental care. So it's not only looking at the dental field, but also at other healthcare professionals. What are their barriers in collaborating with us, for example, in taking up a task at the level of oral health, where they're not necessarily very well educated for. So that's another perspective you can take. You can look at the organization of healthcare, how we can integrate oral health, how we can collaborate better interprofessionally, how we need to organize outreach dental care, how efficient is it, what is the reach of it, how many patients can you see in a day if you go out with your mobile clinic to a nursing home. This is also information that is very necessary to gather. And last but not least, there's this bigger overarching level, the healthcare performance, where you would look typically at the influence of healthcare policies. There's, for example, a very nice paper from Upul Kurei looking at the effect of a change in the co-payment system in Japan, where suddenly at the age of 70, you would have less out-of-pocket spending, and then see would people go
more frequently to the dentist, for example? What is the effect of subsidizing healthcare costs at a certain age? If you would treat oral health, what would be the effect on other parts of the care system? Here, for example, it's treating people with diabetes and then looking at healthcare costs saving at a level of their diabetes, not anymore at oral health. So these are also studies that are very interested for especially at policy level. Where do we stand nowadays? I think we've been, in the last years, we started and we've done quite a bit in describing the problem. We're good at it, like we have a problem, the society is aging. We see this and that, people want that, dentists want that, are they willing to collaborate or not? We've been listening to the different views, but there's still a big gap related to interventions. This is one review that looked at interventions at the level of community nurses, but whatever topic you would take and publish a review on, the conclusion would always be the same, I think, saying that there's a clear gap around research and interventions, and in the future we would need more participatory research, co-design approach, and consider also the complex settings that we very often have to deliver care in. It is a very tough exercise doing health services research. You can have this perfectly designed intervention that in a controlled RCT environment is 100% effective. If you drop it into a real world context, you also need to make sure that it's adopted widely, that intervention, even if it's in a low resource setting like a nursing home, for example, that the local staff chooses to implement it, that it suits them in their daily lives and in their daily work, that it's implementable also at a certain quality level, that you don't lose the whole process, that you reach the persons that you have to reach, also the most vulnerable that need it most, and that you can maintain it and sustain it. And very often those follow-up studies, they end after 6 months, maybe 1 year. Very few go longer in time. Assume that for each of those elements you would have 70% of success, which might look as something good. You end up with an intervention that is reaching only 17% of the end users, and that's the tricky bit. That on paper everything might look brilliant, and then you drop it in practice and you lost it. And then if you have set up this intervention in a very controlled environment, no one will be able to explain why this happens. Why is it not working in real life? And that's why you need healthcare services research, because I mean, if it doesn't make any impact, what's the sense of doing all this work, no? So you will need to work together with people that know a bit about implementation science, and I'm far from an expert from it, but you will have to use theories, frameworks, to before starting your research, and theories is a difficult one. It's a nice quote, they are like toothbrushes. Everyone has one, but no one wants to share or use someone else's. And there's so many theories and frameworks and models that you can apply to design interventions, but there's something to rescue. There is a very nice website, Dissemination Implementation, that will guide you in planning an intervention, in choosing the theories and models you can apply to it, in how you adopt it to the context you want to apply it, how you can combine several models, because it's not because you use one framework or model that you cannot combine it with others, how to use it, how to assess it. So it's a very nice website that will guide you all along the way and will make you choose the right model. In health services research, the most widely used model is the Damm-Schroeder model. It's a consolidated framework for implementation research, and it has been used in a few studies in the field of dental care, but not always for intervention implementation. For example, the framework also has been used to organize determinants of care, to organize the findings of the systematic review, for example. So you can use those models and frameworks also to give structure to your paper and not overlooking any information. And when you look at models around health services research, you will always find the same core principles. You will have an initial intervention that has some core elements that you cannot skip them, you cannot avoid it. But then you will have something surrounding it that is adaptable to the context where you want to apply it. You will tailor it to the individuals that are involved, not only the patients or the populations or individuals, but also the health workers. You will have to adapt it to an outer setting, and this adaptation from I thought the battery was gone. The adaptation from the ideal intervention towards an adapted intervention, this goes through a process typically of co-design, a lot of qualitative research involved, and it mainly is also an iterative process, which means that if you use a framework and a model, it will allow you to go back and forwards and to keep on adapting the intervention as you go along your study, which is a very strange concept if you're used to very clinical RCT studies. There are some key elements I said already a little bit. The context matters. You will have to co-design, you will have to make your intervention adaptable, and you will have to do a process evaluation along the way to make sure that you get an insight on why certain things work in one nursing home, for example, and they don't work in another nursing home. It is different designing an intervention for a Greek old lady living in the countryside, or my grandmother who is swimming with her grandchildren at the age of 92. It's not the same kind of setting, it's not the same kind of person, they have a different background, but they all need access to care and they will have different needs. There's a very nice paper to introduce you into the co-design world of our colleague Paul Brocklehurst. Some of the colleagues are also here in the room. He introduces you a little bit to the different ways of doing this, and there have been some nice papers already showing you how you can apply this co-design into complex interventions, into policy evaluations. It's always an iterative process, but as I said already, you will have, in general, a combination of quantitative methods and qualitative methods. And many of us stick to the quantitative bits, but the qualitative is so important. So try to find people from social sciences that are used to do qualitative research. Let them teach you, because without that, you won't get a full insight on what you're actually doing and achieving. And that will give you an answer, those models, on why the intervention did or did not work, and then at least you can explain, or you have an insight on what you need to adapt if you drag it into a bigger setting. You can use those models for a small bit, and you can start playing with it, you can combine them, so it's not like a very strict environment where you need to stick to a certain model. This is an example, not from oral care, of how it might look in the end. So they used the consolidated framework implementation research as the core model, but then, for example, to evaluate their research, they will look at the RE-AIM model, which is a very known one for evaluation of research. They apply health behavioral theories at the individuals that are involved to plan their research. They use a model for needs assessment. They have things from behavioral change wheel, for example, to plan the implementation. So you can take bits and pieces from different models to come to a well-informed, theoretically based intervention. If you have a trial component in your health services research, which is very logical, there's also a very nice website that can guide you in doing pragmatic trials and put them in a more realistic settings, and they help you in how you should adapt these very
these clinical trials to be more pragmatic and still be methodologically sound. If you are doing this research, in general, you want to do it because you want to change the system, because you see so many things going wrong and you want to do something about it. So it's very important also from the start to look at how will I translate this to policy. And that's not an easy thing. In the special issue, there's a paper of Finbar Allen together with George Stakos, and they spent a part of the paper on this topic, on how to translate it into policy, and they do it based on two frameworks. I'm not going to explain them, but the core thing is that you need to involve them from the very beginning. Ideally, if you get funding for this kind of research and you get it from the government, you discuss with people from the government, from several health departments, on what their priorities are. And for example, I'm the PI now of a big study, and before it even started, it was in the healthcare policies of aging in Flanders, for example, because I had been talking to them and they gave me the money. So then they included into their policies even before having the results. And you need to build trust with policymakers. We tend to stay in the dental school and shout out loud that things are not going well, but people won't listen to us if we don't approach those people that are empowered to change things. And we need to dare to stand up, because if we oral healthcare professionals, even though we are clinicians, I'm also a clinician, if we don't stand up for those people that don't have access to care, who will? If we don't do it, politicians think that things are going well and they don't need to change anything. You need to put an emphasis on the fact that oral health in older adults it's a public health problem. Problems are widely spread. They have a serious impact on society. They cost an awful lot of money. Those that still have the illusion in the room that we will be capable of treating the problems away, we won't be capable of treating the problem away. There will be too many older adults, there will be too much pathology, and no one will be able to afford it. There is no country that will ever pay for treating everything away. Forget about it. So you will have to change the system, do more health promotion, make sure there's more prevention, have other professionals involved that also care about oral health. You need to co-develop, I think I've said that already, and you need to make sure that by the end of your research you have a clear idea of how many resources you will need to implement it. Not only human resources, but also financial resources. But that's what they want to know. What will it cost? And what do I get in return? And that's a question you will have to be able to answer. There are so many nice and beautiful policy documents that have come out over the last 3-4 years. Try to attach your research to those policy documents. They're full of points of action that we should be taking. Link them to those policy documents if you want to make your point towards policymakers, because many of them have signed those policy documents and need to address those things. Also, don't forget to evaluate policies that are already existing in your countries, because those policies very often are implemented not based on research, just because a dental association thought it was a good idea, or a politician is approaching elections and thinks, oh, let's do something for those people, and then maybe they will vote for me. But very often those policies don't work or have even an opposite effect, and it's our task to show that they don't work, or they do work, or they don't have the effect in every population group. It might be a good policy for people between 40 and 60, but the worst policy ever for people above 90, for example, in a nursing home. And that I already said, look at the value-based care. You need to make sure that you have the answer to what it will cost and what will they get into return. If not, a policymaker is not interested. There are some future trends, I think, or things that are like hot topics now in health services research. So if you want to start with something, you might look at one of those, and those are the last slides that I will show. One of those topics is universal health coverage. Some people might not know what it is. It's about having access for as many people possible at an affordable price and have like a basic coverage of the most necessary healthcare needs across your population. You can see there the famous universal health coverage cube. There are some very nice policy documents of the WHO explaining you what it is, how you can approach it, but most policy interventions are working nowadays towards universal health coverage because WHO asks us to. So that's really a hot topic, and there's research going on now in several countries to define what that means at the level of oral health in the different bits and pieces of the population, because essential oral health care might be different in Belgrade compared to Geneva, for example, because resources are different. Digital health, I already said, I think e-health, m-health will play a role. It's also important to achieve universal health coverage. It's a way of making care cheaper. Think about the teledentistry in nursing homes, for example, that provide access to care. Think about way of sharing data. Think about the availability of information. But the main worry I have is what will be the effect of those digital interventions on the older adults, because we need to make sure that it doesn't widen the inequalities in our society, because I'm sure it will benefit many of the younger generations, but I'm not so sure about the older generations. My grandmother, her fingers, a touch screen doesn't react to her fingers because her blood supply in her fingers is not good enough. So she can move as much as she likes. Things are not doing anything. She's not seeing well enough to define things on a screen. She's not willing to learn how the internet works. She says, I'm not going to do this for the last years of my life. And there has been some nice literature already looking at it, but in a broader sense in healthcare. And we see that those tools, they work if older adults are motivated enough and if they have sufficient support. But there's many older adults living alone at home that are not motivated to do this and don't have the support. So then the inequalities might widen a lot. So we need to make sure that those tools are feasible for the older adults, that they're acceptable, effective. And there's no guidelines at this stage whatsoever on how we should use it, what we should use it for, what will be to the benefit of older adults, and what will be a waste of time, and in which settings should we apply things. There are some recent papers coming up at the moment on the acceptability of teledentistry for older adults, for the staff in nursing homes, for example, but there's still a very long way to go. And the last slide is about the use of data. There's an agreement made in the European Union. I know Serbia is not a part of the European Union, but those data will be publicly available. There's an agreement that there will be set up a very huge database, and there's an enormous effort that will be coming reality in the coming years of how to connect data, how to make data available for researchers so we can compare health systems, how they work. We will have claims data across different countries. And AI will also be a part of it, and I think that will open a lot of opportunities to gather evidence more quickly. And we do have a lot of very innovative ways of analyzing data nowadays. We don't necessarily need longitudinal data anymore. We can do causal inference based on observational data. If you use a DAC, for example, you have methods that are coming in from economic sciences, for example, that are now applied in oral health research to get better access on knowledge around health services. So my last quote to end my presentation it's a football coach quote, but I discussed my last slide with my partner and we came up with a football coach quote. And the quote says, I tell the players that the bus is moving. Our aging society, I mean, it's moving, you cannot stop it. And the club has to progress. We have to progress as healthcare professionals. We need to get along with it. The bus won't wait for us. Aging won't go slower because we are not prepared to deal with it. So get on board. Don't wait for things, for disasters to happen. Take action, get out of your dental clinic, take a broader picture, collaborate with others, and try to change the system and try to do some health research that can change the system. Thank you for listening.
Thank you, Professor. Do we have some questions from the audience, maybe? No? Professor Page?
Thank you for your very interesting lecture. So you have already answered a big part of my question. I wanted to know what is your idea to improve health services all over the world, especially in gerodontology. But how do you manage health services in your country? Do you have problems with?
As in any country, we have massive problems. We have a country where there's only one main system. It's a fee-for-service system. So all dentists are sitting in their own private practice. They charge fees, and then the health system will reimburse part of it. Not everything is covered. But we don't have any public health services, for example. So we see that when the individual is not capable of going to a dentist anymore, of taking the telephone and making an appointment, they drop out of the system. So we see older adults dropping out of the system and they just disappear. And no one is taking accountable for it. So dentists, they can refuse older adults because they don't feel like treating them. A person can ask for a consultation at home and the dentist can just say, no, I don't want to do it, and that's fine. No one can tell the dentist anything. So I think if we want to address health services research at a population level, we will need to have some commitment from a government, and you will need dentists that work from the government and that can address quickly the changing needs in the population. Because if we need to wait for the dental profession to be willing to treat those vulnerable groups, we can be waiting forever. I'm sorry, I've lost hope on that front. There's so many research already done, questionnaires asking about willingness in the society among dental professionals. They are completely unaware of the problems outside of their dental clinic. We don't have enough dentists in Belgium. Their agenda is full of easy patients coming every year, every 6 months with little problems here and there. They make, I'm saying it very blunt, they're making easy money. Why would they do that extra effort to look at the unbrushed teeth of those people that refuse care? So it's really a struggle. We do have alternative care systems. I'm the head of a big network where we provide mobile care for nursing home residents, but we are not break even at the end of the year, and the salaries of my team are like 1/3 of the salaries of people in private practice, and you're doing good work, but it doesn't fit the system. So as long as the system doesn't change, people will never be motivated. You need to reward them a little bit for what they're doing, and you need to have systems that are flexible. Look at a country like England, for example, that has an NHS system. Okay, it's collapsing and it broke down, but at times of COVID, they were so quick in organizing vaccinations, for example, because you have a public healthcare system. If you have that at the level in some Scandinavian countries, you have it also at the level of dental care, and there a government says, look, this is your area. You're responsible for everyone in this area, whether they're living in a nursing home, whether they're living at home and cannot attend your clinic, you're responsible for it, and I pay you a fixed salary a month to give care to all those people, no matter what the effort is of their time you're spending on it. So I think, yeah, it's a very challenging thing, and in every country it will be different. And even from one area in a city, it will be different from another area in a city. There's no golden bullet that will solve everything worldwide, I'm afraid.
Professor, we here have young gerodontology researchers, so I would ask you some short message inspiring, like a lecture for these young people who maybe want to embark this journey related to health services research.
Get out of your clinic and speak to the people. To the older persons at home, to their carers, to other healthcare professionals that they're seeing, and try to see where the gaps are and start from there.
Thank you very much. Thank you. As you know, providing oral health care for older adults is very challenging in all fields of dentistry. Today, we have our next speaker, Professor Jugoslav Ilic from School of Dental Medicine, University of Belgrade. He is the head of the restorative dentistry and endodontics department. He is dealing with challenges with our students, teaching them. He is dealing with challenges in scientific work, in his clinical practice. Also, he is a member of distinguished European and national society. So he continuously inspired to find a solution for better care, more effective care for the older adults in the field of restorative dentistry and endodontics. Professor Ilic, the floor is yours.
You. Also, respected Professor Đukić, thank you for the kind introduction. This microphone. As you have heard, Professor Đukić, I'm head of the Department of Restorative Dentistry and Endodontics, and therefore I'm at the first place dealing with the endodontic and restorative problems, and therefore let me first, since I come from the Department of Restorative Dentistry, let me first present you our department with a few words and with a few photos. You can see on this slide where are we located. We are in fact located in this very building where are we now, on the 4th and on the 5th floor. We are one of the biggest departments of our school with more than 50 employees, 25 of which are doctors. You can see our picture on the lower part of the slide, and also I should say that we are hosting more than 33 in fact doctors at the specialization in the field of endodontics and restorative dentistry. We are also holding numerous courses for undergraduating students from 3rd to 5th year, and also in postgraduating students. So we are highly involved in at the first place teaching at our school, but also care providing for our patients. We are not primarily oriented to gerodontology, and unfortunately there are no studies on gerodontology that are going on in our department. However, vast majority of our patients are in fact elderly, and therefore let me say we have a certain experiences with such kind of treatment. Therefore the aim of this my presentation will be to share with you some of our knowledge, some of our recommendations. It will be more like guidelines, since this is very wide area, and time for my presentation is relatively short, so I hope I will tell the most important things. At the beginning, let me say that overall life expectancy increased worldwide by more than 5 years in the first 2 decades of 21st century, and it is at the moment 72 years. On this slide you can see some data from censuses conducted in Serbia we saw earlier some maps with, in some of them, blank area where the Serbia is. So here are some data from Serbia. When we speak about the period between two last censuses, we can see that the proportion or the share of people that are aged more than 65 years increased from about 17% in the census from 2011 to 22% in the census from in the last census from 2022, and the data became available this year. Also, we can see that in the period between two censuses, there was a noticeable increase in the average life, not only in two censuses, but when we look at the period more than 50 years ago, we can see that the average age was, for example, in 70s, 30 years, and now it is more than 40, it is 44 years of old. So it is in fact the trend in our population. On this slide we can see something that in this part of science is called population pyramids, and on the left side you can see the typical look of pyramid of population. This is based on data from 1971, so more than 50 years ago, and by the way, the year when I was born, and that is the last year, to the best of my knowledge, that the pyramid of population was in that normal, let me say, formation. Nowadays, pyramid of population in Serbia is reversed, confirming that the population of Serbia is getting old, and that is the situation not only in Serbia, but in most of European countries, also in most of well-developed countries worldwide. Together with these structural changes in population, the 20th century has brought a dramatic change in dental attitudes, so that an expectation of edentulous in early adulthood has been replaced by the expectation that natural or restored dentition will be preserved. Advances in endodontics and periodontics and also restorative dentistry allowed dentists to preserve more teeth than it was in the past, and progress in implantology also have brought possibility to effectively replace lost tooth. Because of that, people today expect to retain their natural dentition longer than it was in the past. Because of that, also, dental interventions in elderly has dramatically changed in order to include less extractions and more restorative and endodontic treatment. And of course, this kind of treatment in these two fields are not without challenges. These challenges could be grouped in, let me say, three major groups. Challenges from general health, from communication abilities, and age-related changes in oral tissue, mostly hard oral tissue, when we are speaking about restorative and endodontic treatment. Number of studies, including the most recent, reported that the most common diseases in elderly are cardiovascular and diabetic diseases. And according to this recent paper of SINA and the cooperators, systemic conditions, including hypertension and diabetes, take almost 90% of pathology in elderly. Systemic health may have significant impact on dental treatment, including restorative, and in light of mentioned demographic changes, of course, the incidence of this systemic disease has increased. Most of older patients belong to so-called ASA2 class, meaning that they have controlled systemic disease, and fortunately in this situation our treatment, including restorative and endodontic, is in fact similar to the other kind of treatments, and it may be provided in routine manner, however with certain attention having in mind the years and the age of our patient. And speaking of systemic health, very useful tool to estimate the level of difficulty is tool that was presented by American Association of Endodontists. It is called tool for difficulty for assessing of difficulties in endodontic treatment, and it can be used just to make prediction what kind of treatment we could expect when treating our patient. This kind of tool is available even as a mobile application for mobile phones, and it can be downloaded from all known platforms for downloading the applications. However, when planning treatment in these patients, one should estimate the need for some corrections. For example, for correction of dosage of local anesthesia that in some cases should be no more than 2 doses. Eventually shorter appointments, changes in correction of some systemic drugs taking, and so on. The other kind of difficulties is connected to communication. Good communication skills are essential for providers of any kind of elder care, including dental care. Effective communication helps to establish trust between caregiver and the older adult. When dentists actively communicate to their patient and respond with empathy, it creates a sense of safety and security. And to overcome the challenges in communication, care provider, including dentists, can employ several effective strategies. I have listed them on the left side of the slide. Firstly, active listening is very important, if not crucial. Using clear and simple language is important. Non-verbal communication is equally meaningful. Using pictures or features, paying attention to body language, and so on. Communication challenges in elderly can arise from several sources: impaired hearing and sight, that it is common in elder patients, dementia, which is in most situation because of cognitive decline, and also some kind of emotional barriers. And the third, and also one of the very important challenge group, is the group connected to changes in oral environment. Here are some of the specific changes in oral environment. I will stand to changes in hard oral tissues and also in dental pulp. And regarding dental pulp, decrease in local immunity with age may affect reparative abilities of dental pulp, and therefore there were opinions that vital pulp therapy can be very challenging and should be avoided in elderly. However, based on the most recent position statements and recommendations of endodontic societies from Europe and America, age is no longer a limiting factor for performing of vital pulp procedures in elderly, primarily pulpotomies. Also, we should say, and it was spoken yesterday also, that one of the common oral situation in elderly is xerostomia. It is very important because xerostomia can be a predisposing factor for caries, and therefore when we have older patient, it is recommended to ask some simple questions. For example, does your mouth feel dry, or how often does it feel dry, and some kind of clinical also tests like does the mirror sticks to oral mucosa, because this may have significant impact on caries and also significant impact on some preventive procedures that are to be done in our patients. Dry mouth is in older patients in most situations referred to the drugs that they are taking. For example, beta blockers, usually taken by these patients, and similar drugs. Also, may I say that quantitative and qualitative alterations in oral microbiota may occur in elderly, leading to promoted formation of root caries. And speaking of hard dental tissue, we should say that age changes in teeth include physiological wear with superimposed changes in morphology, including attrition and changes in structure and composition of dental hard tissues. The enamel tends to become more brittle and susceptible to chipping. And on this slide, you can see two of our patients that are regular patients of our department, so we can say with high compliance. One male patient, old 87 years, and the female, old of the age of 92. We can see these specific changes in oral tissue, like these cracks, for example, but we can also see that they are dentous, they have their teeth, and also they have this restored dentition. So they are one of the patients that feel it is necessary to retain their teeth in old age. The first age-related change that appears in dentin is dentinal sclerosis, associated with continued production of peritubular dentin as a result of the continuous secondary dentinogenesis. And as a result of that, the narrowing or decreasing in diameter of dental tubules is present with aging. So, the second one is continued formation of secondary dentin that can be very challenging in endodontic treatment. We can see the reduced volume of pulp, reduced pulp horn height, canal obliteration, and also formations like pulp stones in dental pulp. All of this can in fact make our endodontic treatment to be very challenging to be performed. As the pulp ages, it becomes less vascular, less cellular, and more fibrotic, resulting in reduced response to injury and decreased healing potential. There is also reduced nerve supply, which with a greater thickness of dentin can make pulp tasting very challenging. These pulp tissues may be tougher and may not be penetrated as easily with endodontic file as it is in patients in younger age. On these histological changes, histological micrographs, we may see calcifications and also fibrotic changes. Speaking of pathology, the incidence of dental caries is very high in elderly population, and this became very important public health issue since a dramatic increase in tooth retention is here, and we spoke about it. I'll present some studies from UK, China, and America. We can see that in the survey from UK, the number of edentate older adults older than 65 dropped from 79% to 46% in 30 years. And it was estimated in the study from 2000 that by 2028, only 4% of UK population will be edentate. And it was accomplished even before, since in the study from 2021 it was found that already 5% of inhabitants were edentate. The elderly is more likely to develop root caries than coronal one. Since the prevalence in epidemiological studies of root caries was in USA 60%, in China similar 62%, unfortunately I cannot tell you the data from the similar epidemiological studies from Serbia, because there are no epidemiological studies on elderly oral health in our country, so there is possibility to conduct such kind of studies. According to epidemiological data, we saw that root caries in elderly is very frequent. Recession of the gingival margin is common finding among older patients. As the gingival margin recedes, the enamel cementum junction became exposed, and also together with changes in oral microbiota, we can expect the higher incidence of dental caries in this area. About treatment modalities, we should say that these root caries can present ranging from very small, softened, and discolored area of yellowish brown color to very hard one. And also, we should say that if the lesion is non-cavitated, the oral environment may be guided by us to allow remineralization. Frequent toothbrushing with the use of fluoride-containing toothpaste is of great importance. However, if the lesion is cavitated, it is indicated to be restored, but the approach should be minimally invasive. The first option are traditional preparation using burrs. This conventional kind of preparation with the rotary burrs and electric device is well known, and I will not speak about it because it is considered gold standard today. However, we have another kind of possibility. We call it ultramatic restorative treatment, or ART. ART is the kind of treatment where decayed tissue is removed by excavating the infected, necrotic, and superficial dentin, leaving a layer of affecting dentin over the pulp. The technique is characterized by the use of hand instruments under relative isolation, absence of anesthesia, and subsequent restoration using adequate material, in most cases glass ionomer. And also, this treatment is very promising and good alternative for elderly who are restricted at home or living in institutions or with issues in mobility. There are some studies considering this kind of treatment, and for example, in this systematic review done by Maya in 2021, and included 7 studies that were eligible, it was found that the survival rate in this kind of restoration is very high. In 5 years it was about 85%, and that is 85%, and that is in fact very promising for this kind of treatment. The real challenge, in fact, in when restoring the teeth in elderly is in fact some kind of challenge of material to be used. We should also say that during the placement of composite, for example, which is the most frequent restorative material used today, hybrid layer form and the dentin adhesive interface may be defective in elderly. Lopez found that lower adhesion in old dentin exists, and also significantly thinner hybrid layer that may be seen on these micrographs, electronic micrographs. Therefore, because of this, we can say that when speaking of selection of restorative material, chemical adhesion may be more effective for these patients. And speaking of chemical adhesion, glass ionomer cement is such a material. It has self-adhesive properties that is advantages in the treatment of caries of elderly. It is low technique sensitive, and the operating time is very short, and therefore glass ionomer is very good alternative in all the caries when we are restoring caries in elder patients, especially so-called high viscosity glass ionomers with improved mechanical characteristics. Composite resins may be indicated when aesthetic and strength are important, but one should be aware that composite resins restorations lack antibacterial properties and are prone to accumulation of dental plaque. Also, since composite placement is time consuming, in situation where communication with patient is an issue, as I said, glass ionomer can used be more successfully. When treating secondary caries, whenever it is possible, it is most conservative to repair the restoration rather to replace it. Also, since the motto of this Congress is advances in gerodontology. I will say something about the perspectives in the materials. Here are some strategies for developing of new materials. Due to increased biofilm adhesion, changes in microbial structure and load and insufficiency in oral hygiene, it would be preferable for restorative materials in elderly to exhibit antimicrobial properties. The principle for developing of this kind of material was adding antimicrobial agent that could be different and could be in the filler or in the other part of the resin matrix. Also, the second direction is something that is connected to remineralizing materials. The remineralizing materials are made by addition of specific compounds like calcium phosphate or bioactive glass into composite resins to improve their remineralizing properties. And these materials are able to release some kind of ions that could promote remineralization in the tissues beneath the restoration site. The third direction, finally, is the development of self-healing composite resins that contain self-healing microcapsules. When the resin and the filling cracks, the microcapsules are also broken and release healing fluid that is in fact a kind of material that can in fact repair the filling and in that way diminish the treatment need to make another reconstruction. At the end, prevention should be part of any treatment planning strategy. Frequent plaque removal is very important to reduce plaque accumulation. Unfortunately, frail older adults are often unable to brush their own teeth. This can occur due to cognitive defects or physical one. Recommended regimen is using 5000 ppm on fluoride. Also CPP as a me paste or something like that can be used to promote remineralizing. And one important strategy in preventive measures is strategy for patients with xerostomia. This strategy consists of increase of water intake, use of saliva stimulants, and saliva substitutes. The other part of my speaking will be about endodontic challenges, and considering the high prevalence of root caries in elderly patients, in this patients that are need endodontic treatment have significant possibility of some kind of pulpal pathology. Endodontic treatment in the elderly is theoretically the same as the treatment in young patients. However, endodontic considerations in elderly are not without some challenges, and these are relatively recent paper that are telling us the most frequent challenges that are to be met in this kind of treatment. So when treating endodontically elderly, the most frequent are access cavity difficulties, locasing of root canals, necrotic pulps that may be more frequent than in other patients, and also the possibility to find, locate and treat mesiobuccal second canal or mesiobuccal 2 canal. First is diagnostic difficulties. Older patients may have diminished dental sensitivity and pain perception due to degeneration of pulpal neurons, especially in subodontoblastic layer. Therefore, higher prevalence of symptomless endodontic pathologies may remain undiscovered. Pulp tasting plays a vital role in endodontic diagnosis in the elderly. If the pulp space is very calcified, thermal tasting may be ineffective, and the only way to make the diagnosis is to use electric pulp tasting. Diffuse calcifications can generally be observed in root canals of older adults. Severely calcified teeth are predisposed to difficulties in canal orifice location, and moreover, tooth perforation during pulp chamber access of the initial or the initial location of canal orifice may be also difficult. There are several principles that may help in locating of the root canals. They are known as Krasner and Rankov principles, or Krasner and Rankov law, and may be used to make this first step in endodontic treatment easier. Also, the starting point of all root canal preparation procedures is the negotiation and securing of smooth radicular way from the canal orifice to physiological terminus. Calcified canals requiring root canal treatment might have constrictions or denticles all over the canal. We can see that on this first picture. And because of that, it is recommended that the first pass through the canal should be with hand files, small hand files, K files, number 06, 08, or 10. The advantage of using K files hand K files include better tactile sensation, reduced risk of fracture, better understanding of the anatomy, and then after, the specialized mechanized files should be used to establish reproducible glide path for further preparation. One of these files are presented on the third picture over here. So this kind of file may provide us with so-called glide path and allowed us to further proceed with a preparation procedure. And this is the technique that we also use at our department. In this kind of technique, we can manage to treat endodontically even the teeth where on radiography root canals cannot be seen, as in on this picture. Finally, cementum is also deposited gradually over a lifetime. The increased thickness of cementum at the root apex results in increasing the distance between the physiological foramen and the radiographic apex in the elder teeth. So when we look at this picture, we can see that the amount of cementum is greater in older than in younger patients, and therefore the distance between physiological foramen and radiographic apex is higher, is bigger. Therefore, this should have been in mind when assessing working glands radiographically in elderly, since greater distance should be expected when assessing working glands on these patients. Many challenges are to be faced when endo treatment is planned or performed in elderly. Analysis should be done to evaluate cost-benefit ratio. Is it better to do the endo treatment or to do something else? But if the decision to perform endo treatment has been made, then some of the precautions should be taken. They are listed on the slide. Despite changes in pulpodentinal complex, endodontic treatment can be very predictable and effective mean on maintaining the dentition in elderly. And on this slide, you can see one of my recent patients, aged 72, with endodontic treatment as a preparation for prosthetic reconstruction in these teeth. It is clear that there is a growing need for restorative and endodontic interventions in elderly. Emphasis must be placed also on preventive regimen and treatment delivery, which is sympathetic to the changing needs of our elder part of population. Additionally, also training and education in the gerodontology is of high importance, and in light of this, and also in light of changes that are proposed by the European directive for the dental education, we have introduced gerodontology in our curricula. Gerodontology at the moment is elective at our school, but hopefully it would be compulsory and therefore meeting the needs of the population that are getting older. Thank you.
Thank you, Professor Ilic, for your very educational lecture. I have a question regarding bioactive materials and their use in diabetic patients. Does this existing bioactive materials can overcome the diabetes-induced alteration in dental pulp tissue, or do we need maybe some potent bioactive materials to develop? You said we have future materials on the basis of antimicrobial effect, remineralizing effect, or self-curing. What about some pharmacological agents to help the pulp or the dentin to express their bioactive molecules and start that reparative process?
Have some researches regarding diabetic patients. I suppose that is why you are asking me such kind of a question. This kind of materials, let me call them remineralizing materials, or materials that have remineralizing properties, exists at the moment. For example, glass ionomer are considered to be such kind of materials. They have a kind of property that can induce remineralization of tissues that are beneath the lesion, and also some kind of composite materials, or materials that are close and similar to composites like compomers, may have possibility to release the ions. However, they are not still maybe named bioactive materials, because such kind of remineralization of tissues beneath are not registered. But of course, the field is very open, not only for remineralizing materials, but also for materials to contain some kind of for example, pharmacologically active materials that could induce some kind of pulpal response, or to improve pulpal response in special conditions such as diabetic one. So it is something that should be the field of further research.
Thank you, Professor Ilic. Do we have some questions from the audience? No? Thank you, Professor Ilic, for your... With this, we conclude this inspiring session of the lecture, this morning session. Now we are going to a short 10 to 15 minutes coffee break, and we are starting with the session number two. Pardon.
Colleagues, it is a pleasure to greet you from here today. I wish you good afternoon and welcome to our second session for today that will be moderated by our esteemed colleague, Professor Asja Celebic from the Department of Prosthodontics at the University of Zagreb School of Dental Medicine. And I am Marija Milic from Basic Dental Sciences Department here at our School of Dental Medicine in Belgrade. For this session, we'll have pleasure to hear two speakers that will share with us current challenges and treatment modalities for temporomandibular disorder and oral hyperfunction in older adults. As the session starts, we would like to wish a warm welcome to our first speaker, Professor Irena Mladenovic, who is coming from the University of East Sarajevo, where she works as an associate professor in prosthetic dentistry at the Faculty of Medicine, and also she holds the position of a Vice Dean for Education at the same institution. She has been leading researcher in several national and international projects, and her scientific focus is on temporomandibular disorder and orofacial pain and their connection to structural, genetic, and psychosocial components. Professor Mladenovic will discuss different aspects of TMD in adult patients with us today. It is a pleasure to have you here today.
Thank you for this warm welcome. I hope that we hear each other well. Is it okay? Because there were some problems with hearing. So, first of all, dear chair ladies, dear colleagues, or I should say hello everyone. I'm really happy and honored to be here in front of you, and I'm really grateful to Alexandra, our Professor Popovac, Professor Stančić, and Professor Milic-Lemic, who invited me here to be among the distinguished lecturers for the 34th Annual Congress of European College of Gerodontologists. Second thing that I should not miss to greet you all on behalf of my colleagues from Prosthodontic Department and the entire Dentistry Department at the Medical Faculty University of East Sarajevo. I would proudly say that more or less all of us are students of this school, and we are really thankful for that. So I'm coming from the prosthodontic department, but actually I will speak about temporomandibular disorders or TMD in the in elderly population. Why is that? As you heard, that is the part of my everyday clinical practice and also part of my research in, let's say, last 15 years. So I will try to give a current approach regarding the clinical appearance, risk factors, and the most important, the treatment need of this specific group of population. Why is that? First of all, there is scarce data about TMD in elderly, more or less scarce. The diagnostic for TMD in elderly is not so well established comparing to other groups. And finally, there is no clear protocol for TMD treatment in elderly. In this half an hour that I've been given, I should answer these three crucial questions. What do we know about TMD in geriatric population? What are the risk factors? And how to treat TMD in this specific group? So let's start with this, what do we know? I don't like definitions, but just to be clear about it, temporomandibular disorders, or TMD, also known as craniomandibular disorders, or CMD, is a huge group and umbrella term that embraces a large number of various clinical conditions which may involve masticatory muscles, temporomandibular joint, and adjacent structures. Let's see the prevalence along the lifespan. As you probably you're well aware that the peak of the prevalence is actually in this childbearing or reproductive age, generally speaking about TMD, which is from 20 to 40, 45 years of age. And then it gets decreasing up till the elderly. And according to some results, it become completely absent or rarely absent in those aged over 80 years. Why is that? Why the prevalence in this population is lower? One of the reasons might be that these patients have minimal clinical symptoms. It's just like that. They also unlikely ask for the treatment, not just because these symptoms are minimal, but also they have a burden of the other comorbidities, a lot of systemic diseases, which of course play much major role, and they are focused on those changes. Also, some hormonal factors may play a role. I'm speaking about sex hormones, and I will talk about it later. And also psychosocial factors decline in this, luckily, in this group. Under the elderly with TMD, there are some differences. Of course, the lower ages, like up to till 7, are more prone to develop TMD than the females, still up till 80s, and some psychosocial disorders like depression, stress, etc. And also, it has been observed that patients with other pain conditions are more prone to develop TMD as well. Regarding prevalence of TMD, the data are really various, coming from 3 to 90. I mean, 90 is too much, just if we focus on the symptoms and signs, but regarding diagnosis, it's from 3 to 12, let's say. And according to some Scandinavian studies, 4% of these patients consider by themselves report severe symptoms. I will just say a few words about typical clinical picture of these patients. They have one or more of these signs and symptoms, which is changes in the mandibular movement, pain in the temporomandibular joint and the masticatory muscles, and also some sounds in the temporomandibular joint. What is about these signs and symptoms which is typical for the high age group is that the changes by the type of this displacement decrease in this age from 60 to 40%, while inflammatory degenerative disorders increase up to 95%. So, I told you already that the peak of the prevalence of TMD is in the reproductive age, yes, for TMD in total. But if we speak about the degenerative or inflammatory degenerative diseases, which are intra-articular changes like arthritis or arthrosis, there is another peak which happens actually in 55, 60 years, so it happens 14 years after. So that's what we know, and also, happily, we know something about the risk factors for TMD in geriatric patients. When I speak about etiology of TMD, I have to say something about this man and the paper, the famous paper of Costen, a famous English otorhinolaryngologist. It was published almost a century ago. Yeah. And we still speak about it, at least some dentists. It was a paper regarding mandibular joint neuralgia, also known as Costen syndrome. The revolutionary thing was that someone at least spoke about temporomandibular disorders for the first time. Actually, muscles were not spoken about in that time, but temporomandibular joint. And except that the problems actually pain in temporomandibular joints and some sound. He also had some otologic symptoms like impairment in hearing, nausea, and dizziness, etc., etc. And everything would be fine, except that Costen said that the only reason for this to happen is occlusion, meaning that lack of teeth, a low number of teeth, and lack of posterior support lead to all these symptoms. And okay, he told us that, but generation of dentists, including me, I'm not that old, but we have been learned, at least at the basic studies, that the occlusion is the only reason for these people having, people in general having problems with temporomandibular joint and masticatory muscles. And still, I have some requirements of the older dentists, I would say old school dentists, to try to help them by replacing their teeth. After all, I am prosthodontist. It's not, I think that is the basis for the thing that in the most schools, at least in Europe, prosthodontists treat temporomandibular disorders. It stays from that time when the occlusion was the center of the universe, I would say, in this story. Nowadays, we know that it's multifactorial in origin, and a lot of factors beside occlusion or structural factors may play a role, like psychosocial factors, biological factors, and trauma. Let's start with something that is clear. Both macrotrauma and microtrauma may play a role in development of signs and symptoms of TMD. You're well aware that physical injury plays an important role in development of these symptoms. And regarding elderly, not just macrotrauma, but microtrauma, including nail biting, clenching, then tongue thrusting, pencil biting, and etc., may have a role. And I also have to stress this kind of trauma. Yes, if we have an intervention that is, it does not have actually to be prolonged, but just if the patients have a kind of predisposition, it might happen that they develop luckily some transitional, but they may develop signs and symptoms of TMD. For bruxism, there are reports that those patients old patients having bruxism can increase the odds of developing of TMD 3 to 6 times. So those individuals that are self-reporting bruxism also have higher prevalence of the limited opening, temporomandibular joint pain and sound. So it's quite clear about it. What about occlusal factors itself? I already told you that at least Costain and the numerous papers later up till, let's say, 80s, 90s from last century spoke about lack of teeth and a small number of teeth. There is a reference even from 90s pointing out to this factor. Then removable dentures in general and complete dentures. So although some older papers speak about the connection or association between TMD and wearing complete dentures or having low number of teeth, some more recent, I would say, references says that those elderly that reported a lower number of teeth or the presence of removable dentures, they had not higher prevalence of signs and symptoms of TMD. One proof that speaks about the connection about the loss of teeth and temporomandibular disorders is this diagram. TMD symptoms even seem to decrease with the age, while there is a further loss of teeth. So it could not be connected by any mean. Then, interesting thing, okay, people do not have prostheses. Their own teeth. Sometimes they need to get some dentures, and the dentures could be, weared in our country. In my patients sometimes wear those dentures for 20 or 30 years. Believe me or not. Of course, those are some just cases, but generally like 10 or more years. In that time, those dentures might come unstable, non-retentive. There is occlusal instability as well. because of the wearing of teeth, the central relation is not anymore stable, and also the vertical dimension goes lower. So some of these factors have been accused of developing TMD, even in those that have dentures. But some other references say that there is generally low prevalence of TMD in these elderly patients wearing dentures, and also they found no relationship between TMD and the retention, stability, interocclusal distance, centric relation, and balanced occlusion in denture wearers. Let's speak a little bit about psychosocial factors. Regarding elderly, it is well known it is connected to TMD, okay, but in elderly, what has been found that they usually develop, they could have those elderly with TMD depression, but it is not a diagnosis of depression, it's just signs and symptoms which are luckily mild. The same, and higher in the, it was higher in comparison to the controls. Then anxiety, also mild symptoms of anxiety, and it was higher in those with myofascial pain and this displacement, also stress and some somatic problems. What is specific for elderly is this social disconnection, which means that these patients frequently have a low interaction with other people, small social network, which unluckily can lead to the depression and anxiety, but also not all of these elderly patients need psychological evaluation and management. Biological factors, including gender and some other biological factors. What about gender disparity in TMD prevalence? It is well known that there is a huge discrepancy among women and men when we speak about TMD symptoms. In the clinical population, the ratio is from 3:1 up till 9:1 for ladies. But that's in general population. In this higher ages, as you see, beginning from 50s, like premenopause and menopause, it got slower. They're getting lower, and somewhere in the 80s, the symptoms got same. That is explained by not just by the level of estrogen and progesterone, but the changes, normal changes during the menstrual cycles, and also these huge changes in the menopause and the menopause, and after that, the symptoms stop. Biological factors, when we speak with about elderly, there is quite huge prevalence of TMG degeneration, which I would say you could rarely see it in younger. So it goes up to from half of the investigated elderly people that have TMD up till 70%. More prevalent in women, and the symptoms are luckily in majority of these patients that develop symptoms are minimal. They're also self-limiting, which means they resolve somehow in 5 to 8 years, but just in some small part of these patients, in 50%, they somehow got into progression. Regarding etiology, there are several possible explanations for this TMG degeneration. First of all, the remodeling and entire repair process is the capacity is lower, of course, in the older patients, regarding cartilage especially. Then regarding women and higher prevalence of TMG degeneration, the reduction in estrogen could play a role, and also presence of osteoarthritis, either it is local or part of the systemic diseases, may be behind this. So that's what we know about risk, and what could we do about these patients, or how to treat them if it happens that they develop signs and symptoms of TMD. There is not one management option. There is a whole spectrum of the various types of treatment modalities, including home self-care, education, behavioral therapy, then pharmacological therapy, physical therapy, just for rare cases, surgical therapy, and of course majority of us are dentists. We should say a few words about the possibilities of occlusal treatment. There's a nice paper with this recommendation saying that since it is really difficult to distinguish those geriatric patients with self-limiting TMD and those that are going to get progressed in some time, you should always consider the conservative, the less invasive treatment modalities in all geriatric patients. So you should try with the education, with jaw exercises, or with some easy home physical therapy like massage, like thermal therapy, of course dietary advice, avoidance of parafunctional activities if they are present, and of course if there is a pain, non-steroid anti-inflammatory drugs and muscle relaxants could be of help, also some other groups of drugs, but only if these non-invasive treatment modalities does not help, then you should think about something else. Starting with education, you should spend some time with those patients speaking about it. It's very important, and believe me or not, it is going to influence the further development of diseases and their reaction to the treatment. So you should explain them just shortly about the etiology of these disorders, and the etiology in this case. If you have models or some posters or flyers, you should explain the anatomy shortly. And what is important to explain them the nature, which is in majority of patients, the nature is benign. So it just helps them to understand and to be less worried, and also to propose them the possible treatment modalities. Let's start with home care. You should advise your patients to get to sleep hygiene, because the normal rest, normal rhythm of the sleeping is really important regarding development of pain. Then to lower caffeine consumption, to avoid parafunctional activities if there are any, of course for the day parafunctional activities, and also to alter logically dietary consistency, soft food, cut it into the pieces, etc. What they could really do by themselves is use of warm compression or ice compression, especially if there is a pain. Of course, regarding inflammation and the acute trauma, you should not give them warm compression, you know that, for any other reason. So massage of the superficial muscles like masseter and temporalis, and jaw exercises. What about pharmacotherapy? It's okay, it is useful. Sometimes it should be the first line in patients with TMD pain, but you should know that those data that we use for everyday clinical practice for TMD are generally based on the management of other pain conditions. So we extract data from other pain conditions, and because the data on TMD are quite limited. I don't say that there are not any, but they are limited. So what you should consider, starting from analgesics like paracetamol or acetaminophen, as it is called in other parts of the world, non-steroid anti-inflammatory drugs like ibuprofen. What is important that you should use them at least 2 weeks and not more than 4 weeks, because these negative effects on the gastrointestinal tract, and also not to use them by need, but regularly 3 times a day, and doses depends on the intensity of pain. what's good thing is also to think about combining these medications together, and also give the magnesium with them. Magnesium is not analgesic, but hires the effects of the analgetics to get a lower pain, especially for the temporomandibular joint pain. If there is a muscle pain, then you should consider muscle relaxants like cyclobenzaprine and anxiolytics. We don't give them anxiolytics to lower the anxiety in these patients, although it can be present. But we use their muscle relaxant effects. So both of them, like diazepam or cyclobenzaprine, you should use them once a day, maximum 10 to 14 days. Corticosteroids, in everyday practice, you will not use it. I'm just telling that it might be helpful, especially locally, intraarticularly applied in patients with temporomandibular joint arthritis and some other conditions. And you should refer these patients to the specialists. For chronic pain, there is no need or reason to use these analgesics and non-steroidal anti-inflammatory drugs for prolonged period. You should use antidepressants or antiepileptics, or just refer those patients to subspecialists of pain medicine or us that are dealing with temporomandibular disorders. So those drugs are introduced gradually, used for several months, and also the doses are getting low, gradually getting lower, and usually we have good effects of these medication, although in some patients the pain got back after a year or years. Of course, I have to mention occlusal treatment. I have to stress that you should consider reversible measures of occlusal treatment always when you can. There is no scientific data that irreversible occlusal treatment like grinding, prosthetic therapy, orthodontics, etc., will help people with TMD signs and symptoms. Just use these simple measures like stabilization splint, anterior repositioning, or anterior bite splint. It depends on the indication. I have no time to explain that anymore. Of course, soft splints, they are actually very useful for the temporomandibular joint pain and also this displacement, and also soft splints for the night parafunctional activities. But most of those, at least in this region, most of these people, elderly people having TMD, are completely or partially dentulous. So, of course, it is not forbidden to replace the worn denture or to give them new dentures for the first time. Of course, if those dentures have a proper retention, stability, occlusal stability, good central correlation, adequate vertical dimension, of course that you get the better condition, and these better condition in the entire orofacial system leads to possibly reduction of TMD symptoms. But you cannot think just locally. Temporomandibular disorders, as I said, is multifactorial in origin. There is a well-established biopsychosocial model, so you cannot do only on the local part. You have to think about social, psychological factors, some biological factors to deal with them together with this in order to have decrease in the signs and symptoms of TMD. And of course, if you have pronounced symptoms, as I already told you, you should think about referring those patients to pain or TMD specialists. I will just say a few words about these pronounced symptoms, especially for the TMD degeneration. Some older patients get well with the arthrocentesis in initial method, if those initial methods do not give you good results. In some really rare cases, but the new results of the maxillofacial surgery in temporomandibular joint is quite optimistic, you should think about the Team G implants or Team G replacement. But those are really, really rare cases. So finally, I will give conclusions, starting for these 3 points I gave at the beginning. Because early detection of signs and symptoms and diagnosis of TMD is crucial. If you catch it at the beginning, good results, good treatment results are much more frequent. So we should maybe think about just short TMD screening in those patients when they come dental office. Then it's a question for scientists. Maybe some diagnostic criteria should be adapted to the elderly, just like we have some adapted for the children population. And always think about reversible treatment as the first-line treatment for geriatric patients. With these few pictures from surrounding of Foča, I would like to thank you for your attention. If you're likable, if you're fond of hiking, trekking, or canyoning, those are my pictures. It's really a paradise over there, and you're always welcome, just as you're welcome to our dental school. Thank you for your attention, and I'll be pleased to answer your questions.
Thank you, Professor Mladenovic, for this very insightful and comprehensive lecture. We're now moving on to short discussion. Do we have any questions from the audience for Professor Mladenovic? Not for now. Then I will ask Professor Celebic to start a short discussion.
Very much. First, I'd like to thank you for your informative lecture, and I would like to raise some questions related to aged population. Generally, temporomandibular disorders are decreasing with increasing age, but I would like your opinion about the diagnoses that are decreasing, and maybe some diagnoses are increasing with higher age. What's your opinion?
Thank you for your question, Professor Celebic. So, as I already told you, these displacement disorders are getting lower, while the degenerative and the inflammatory diseases getting higher. Why is that? I give some explanation, possible explanation regarding estrogen in women, because it is more prominent in women, the degenerative diseases, then let's say some osteoarthritis, which could be related to the general present osteoarthritis in these patients. So some laboratory testing should be done in these cases, and then usually we send those patients for that kind of analysis. And also everything gets it's weird, you know. And also the cartilage cannot bear all the burden that temporomandibular joints still have to deal with in the elderly. So that might be the explanation. On the other hand, pain-related symptoms are getting milder, and somehow they just disappear without any intervention, and they are minimal. Of course, regarding women, because they are majority of the normal, I would say, general TMD population, hormones, when they stop to work, we are at least have no pain. I mean, we are without that. That's good point of all of it. So those are the explanations.
I'd also like to ask another question, because in complete denture wearers, the temporomandibular dysfunction is decreasing. And what is your opinion? Why is that? Is it because the tension of that patient switches to problems with chewing with complete dentures? instability, sore spots, and so on. And it is not on the joint anymore. Or is it maybe because they chew with lower forces and there is less strain in the joint, or maybe a combination or some other factors that can be addressed for that?
Thank you. That is the fact. But actually, I would more say that the temporomandibular disorders, signs and symptoms in denture wearers are similar to the controls. I mean, to those that have elderly that have teeth. They are not lower, not higher as it was as it was taught before. They are similar. Of course, when you introduce something that should help those patients to develop normal functional activities, normal position of the mandible, normal position of all the structures of the orofacial system, just you get a kind of balance in there. So that would be a kind of explanation. Although those not wearing dentures does not mean that they are going to develop signs and symptoms because of all these factors that I explained before. So those might be the explanations.
I have one short question regarding the biological factors that you mentioned. You mentioned estrogen and sex hormones, and on that graph, melatonin was also presented. To your knowledge, in the literature, is there any connection with sleep quality and prevalence of TMD in older patients? Does that imply that maybe some poor sleep quality might increase the risk?
Thank you. It's really interesting point of view, and as the psychosocial model of TMD has been introduced, everything is repositioned from the local to the central story, let's say, and everything is being monitored, and is monitored from the central nervous system. If you don't get enough sleep, of course, the normal functioning of the central nervous system, the control of pain, especially those inhibitory effects of the downstreaming pain-related control, it does not work. So it's not that patients are imaging they're having pain. They really have impaired mechanisms to cope with that pain. Adding some social, so the pain is interesting thing because it does not depend only from the problem itself, but from the perception and from the how to say fabricating all these things, and all goes from the central nervous system. Yeah.
Thank you, Professor. That would be all.
Okay, thank you. Now I'm pleased to announce the next speaker. She is esteemed researcher and she is associate professor from Tokyo Medical and Dental University. Her name is Yuriko Komagamin. I hope I pronounce it in the right way, because she is from Japan and I'm not sure about the pronunciation. She is esteemed researcher. She has more than 500 citation in Web of Science and about 50 recognized articles in high impacted journals. And I'm looking forward to hear her lecture.
Hello everyone, I'm Yuriko Komagamine. I came from the Tokyo Medical and University in Japan. First of all, I would like to say thanks to the person who organized this wonderful congress. Thank you very much. Today's my lecture title is Interventions for Oral High Function, Occlusal Force and Oral Dryness.
Hello. Yes.
Okay. This slide shows today's contents. First is oral frailty. Oral frailty is defined as a series of phenomena and processes that worsen due to change in various oral conditions. Recently, it is reported that a decline in oral function appears in advance of physical dysfunction. If the person represents oral symptoms such as loud speech, spilling food from their mouth, increasing food, no chewing of food, and choking, they will be diagnosed as having oral frailty. If the oral frailty progresses, the person should represent oral symptoms such as poor oral hygiene or dry mouth, a decline in occlusal force, and decrease in tongue and lip function, and decline in masticator or swallowing function. This stage is oral high function. If the oral frailty progresses more, the person will represent more masticator disturbance and dysphagia. The person with oral frailty have several risk factors such as frailty, sarcopenia, requiring the nursing care, and death. Risk of those events with oral frailty is twice compared to without oral frailty. This is a checklist of diagnosis for oral frailty. The checklist is comprised of 8 question items. Difficulty is in eating hard food compared to 6 months ago, choking, wearing a denture, experience of dry mouth, decreasing going out compared to 6 months ago, having ability to eat hard, teeth brushing more than twice a day, visit to a dental clinic once a year. If oral symptoms meet more than 6 scores, the person will be diagnosed as having oral frailty. Recently, the short version called OF5 is developed. OF5 is comprised of 5 question items: number of remaining teeth, difficulties in eating hard food compared to 6 months ago, choking, experience of dry mouth, slurred speech. If oral symptoms meet more than 2 years items, the person will be diagnosed as having oral frailty. I move to oral high function. The Japan Society of Gerodontology proposed a concept of diagnosis of oral high function in 2016. The oral high function is diagnosed from the 7 items. In the stage of oral high function, it is important to detect and treat the oral high function in dental clinic. So the dentist should check if the older adults have oral high function or not. If the older adults have oral high function, they should treat them. As the diagnosis of oral high function, if oral symptoms meet more than 3 items of 7 items: poor oral hygiene, reduced occlusal force, decreased masticator function, decreased tongue limb motor function, oral dryness, decreased tongue lip pressure, deterioration of swallowing function, the person will be diagnosed as having oral high function. In Japan, the examination and treatment of oral high function is covered by insurance. The floor is the insurance treatment of oral high function. In the flow, dentists provide guidance on oral function training to the patient, but the oral function training, no confirmed oral function training is there. There is no confirmed oral functional training yet. In local government in Japan, prepare for the guidebook that about oral high function and distribute them to the residents. In the previous studies, several oral function training is introduced. For example, lecture, oral hygiene guidance, stretching training, gum chewing training, stretching, salivary gland massage. Among them, gum chewing training is inexpensive and easy to obtain and having stress relieving effect and being less residue in oral cavity. I introduced the previous studies that examined the gum chewing training on oral function. Nakazawa reported that in the prospective study targeted older adults, 1 month gum chewing training improved significantly masticated function and physical ability. Shirai reported that in prospective study targeted on adults, 1 month gum chewing training significantly improved maximum occlusal force. In the prospect study targeted at older adults, 2 weeks of soft gum chewing training and followed by 2 weeks rest time and then 2-week hard gum chewing training significantly improved resting salivary flow and maximum occlusal force. In the randomized control training, control trial targeted at junior high school students, the intervention group performed 1 month gum chewing training and the control group performed no training. As a result, maximum occlusal force in the intervention group significantly improved compared to the control group. In the randomized control trial targeted on adults, in the intervention group performed 3 months gum chewing training and the control group performed no training. As a result, tongue pressure and cheek pressure in the intervention group significantly improved compared to the control group. So it is considered that gum chewing training improved some items among 7 items related to oral high function. So I introduced to our research that examined the gum chewing training on oral function. Firstly, we conducted the preliminary study. In the randomized control trial, targeted 65 older adults, 130 in total. The intervention group performs 1 month gum chewing training, and the control group performed tablet intake, 1 month tablet intake as a dummy intervention. As a result, tongue pressure in the intervention group was improved compared to the control group, but there is no significant difference in maximum occlusal force as primary outcome. And the chewing time of a day in the preliminary study is about 6 to 7 minutes a day, but in the previous studies, chewing time a day is 15 minutes, so short gum chewing time causes possible reduction of load chewing training, and there is significant increase of some outcome within group comparison to the control group that cause possibility of training effect from tablet chewing. So we decided to improve training chewing gum and extend duration of chewing training and change to test foods that need less chewing load in the control group. So based on the results of preliminary study, we conducted a new study. In the randomized control trial, we targeted on 109 older adults, 218 in total. The intervention group performs 2 months gum chewing training, and the control group performed 2 months granulated food intake as dummy intervention. This is eligibility criteria and exclusion criteria. Individual age 65 to 85 years and those who complain about inability to masticate stiff foods in comparison to 6 months ago were main eligibility criteria. In the intervention group, one gum chewing twice per session, 3 sessions a day for 2 months is intervention. In the control group, 1 package of the granulated food per session and 3 sessions a day for 2 months is the intervention. Regarding experiment chewing gum, the size and weight hardness was modified, and the participants in the intervention group were instructed to the chewing gum to chew until they feel the granules included in the gum disappear. In the regarding experimental granulated food, the granulated food like powder, so the participants in the control group were instructed to dissolve them in the water and ingest them. Primary outcome is occlusal force, and secondary outcomes is occlusal conjunctive area, resting salivary flow, temperature, tongue mode function, masticated function, and chewing time. This is the results. 107 in the intervention group and 104 in the control group complete the intervention and were analyzed. Regarding baseline characteristics, there is no significant difference between the groups. Regarding group comparison at pre-intervention, there was no significant difference between the groups. Regarding the group comparison at post-intervention, there was a significant difference in maximum occlusal force. The maximum occlusal force in the intervention group significantly improved compared to the control group. Regarding within group comparison of the intervention group, there was significant increase in several outcomes between before and after the intervention. And regarding within group comparison of a control group, there was a significant increase some outcomes between before and after the intervention. 2 participants in the intervention group dropped out, so this chewing gum training is easy to perform and continue for older adults. And the maximum occlusal force is in the intervention group significantly improved, so this chewing gum training might occlusal force. And the time of chewing per day in the new conducted trial is 13 to 4 minutes a day, longer than the preliminary study. So in addition to improvement of training chewing gum and extend duration of chewing training, And this training, this chewing, the longer extension of the time of chewing per day is contribute to the improve of occlusal force in the intervention group. As a conclusion, within the limitation of this study, chewing training wisdom might be effective in improving the maximum occlusal force among older adults. And I'd like to introduce another our research for oral dryness. Among the 7 items related to oral high function, I would like to focus on oral dryness. Regarding oral dryness, there may be about 30 million potential cases of oral dryness in Japan. 56.1% of the older adults were aware of oral dryness, and 27.7% of the older adults were aware of oral dryness at all times. As main treatment method of oral dryness, oral medication, salivary gland massage, moisturizer is popular. But oral medication cannot be obtained without prescription, and moisturizer is not a causal treatment. And salivary gland massage is said to be safe and easy method. Salivary gland massage is stimulating major salivary gland, parotid gland, submandibular gland, sublingual gland by fingers on the skin. And regarding the previous study that examined the salivary gland massage on oral function, in the randomized control trial, target independent elderly women, the intervention group performed patient education, facial and tongue muscle exercise, salivary gland massage, and the control group performed no intervention. As a result, there is no significant difference between groups, but in the only intervention group, oral uncleanness, tongue dryness, swallowing function, and salivary flow and tongue motor function significantly improved. And in another randomized control trial targeting on community-dwelling elderly people with oral dryness, the intervention group performed oral hygiene guidance, facial and tongue muscle exercise, salivary gland massage. The control group performed only oral hygiene instruction. As a result, there was no significant difference between groups, but in only the intervention group, repetitive salivary swallowing test, taste threshold, resting salivary flow significantly improved. In Japan, the local government prepared for the pamphlet about salivary gland massage for prevention of the oral dryness of older adults. But it is considered to be difficult to make the quality of massage uniform. Vertical vibration machine is a training machine that generates 3-axis vibration. This machine is considered have a beneficial effect in medical sports medicine. So we hypothesized that the salivary gland massage with this machine can make the quality of massage uniform. So we conducted the research to assess the effect of salivary gland massage using a vertical vibration machine on oral dryness in older adults with oral dryness. The sample size of the participants is 17. Eligibility criteria is those who be under either mucus of less than 27 or resting salivary flow or 0.2 gram or less for 2 minutes. The method of salivary gland massage with the device, firstly placing the cushion material on the plate and placing an elbow on the material cushion material and applying the vibration to the salivary gland through fingers. Some was placed on the submandibular gland, and the remaining fingers is placed on the parotid gland. This method is regarding this method, one set for 3 seconds, 3 sets per day. The massage was performed twice a week, 8 times a month in total. The outcome is resting salivary flow by spitting method and oral moisture measured by mucus and subjective evaluation measured by questionnaire. The question items is shown in this slide. As a result, this is the characteristic of 17 participants. And regarding resting salivary flow, compared to the pre-intervention, there was a significant improvement in resting salivary flow after the intervention. And regarding oral moisture, compared to the pre-intervention, there was a significant improvement in oral moisture after the intervention. Regarding questionnaire, there was a significant increase in some question items such as Q1, Q4, Q5, Q6, Q7. There was one previous study that used mechanical device for salivary gland massage. The participants wore the mouthpiece device covering mandibular dentition for 10 minutes a day for 1 month. The device includes in salivary flow by both contact stimulation to turn of the device and electrical stimulation to turn through the device. There is a significant increase in resting salivary flow after 3 months use of the device, but the authors reported that 27% of participants show oral mucosal disease, but the disease disappeared during the intervention period. So the method in our study is safer than the method in the previous study. Training time a session in the previous study is 90 minutes to 120 minutes. In case of our research, it is 90 seconds in total, and training duration in the previous study is 3 months. In case of our research, it is only 1 month. So the method in our research is improve oral dryness shorter than the methods in the previous studies. As a conclusion, within the limitation of this study, salivary gland massage using a vertical vibration machine applied twice a week for 1 month to older adults with oral dryness might improve resting salivary flow and oral moisture. This is summary. Oral frailty is concept, whereas the oral high function is disease, and gum chewing training might be effective, and massage using a vertical vibration machines might be effective. This is all my presentation. Thank you for listening.
Thank you, Professor Komagamine, for this lecture, for sharing your experience and knowledge on this topic with us. Do we have any questions from the audience for Professor Komagamine? Not yet? Okay.
Okay, I'll ask you a question. I don't know if I understood in the beginning of your lecture, you mentioned that by chewing gums, the persons not only increased oral function, but also overall physical activity. I would like, am I right? If did I understand in the right way?
You asked the effect of the chewing gum will the physical function. From our researches, the effect of the gum chewing on the physical function is not it was not investigated, but recently the effect of chewing on the systematic disease is reported in some researches. So we would like to investigate the association chewing and systematic disease from now.
Thank you, Professor Komagamine. With this lecture, we conclude our second session. Now it's time to join us for a lunch break, and we're inviting all of you to meet us at the Faculty Club. We would like to thank our speakers once again, and all of you for your enthusiasm and attendance. Thank you.
Hello, friends, colleagues and friends. Yes. Hello. Yes, it's working. So we are at the end of our 34th Annual Congress of European College of Gerodontology. I'm so happy that we had two really successful days, both in scientific way, but also as a great gathering of all people from Europe, from region, from Japan. So I think we had a really good future collaboration all together, and we are already planning. So we have several awards. 3 for poster presentations and 1 the big ECG award. And I called Professor Aleksandra Milic-Lemic to announce the winners for the poster presentations.
Thank you. Thank you, Sanya. Thank you all for waiting on 5 o'clock Friday PM. It's too much. But I think that the 3 of you will be satisfied with our results. Okay, for the best case report, Jelena Vucetic. For the best original research award, Hinako Takano. And for the best young gerodontology researcher, Manisha Rahaman. We were waiting for her. She didn't know if she would come to Belgrade or not, but this was destiny. Is it okay? It was my pleasure. Yeah. I think that we were all waiting for this reward. Is it okay for there? Oh.
Who got it? Who got it? And I couldn't tell, of course, until this moment. Yes, and just for the 2 awards from for these money rewards, I will tell you later how can you receive it from our sponsors. Yes. And for our big ECG award, it was really heated discussion, but I think it was clear that Professor Soraya Leon is our winner. Yes. To come across the globe.
Yeah.
Viva Chile! Viva Chile! Yes. So I really hope that next year we will see each other again in Geneva, and we will continue our collaboration. Of course, Anastasia, please tell us something. The date, yes, it is August 29th, 30 or 20? No. So it is August 29th and 30, 2025 in Geneva Dental School. So save the date and we will see each other there. Anastasia, please.
Before concluding, and as Secretary of the European College of Gerodontology, I would like to deeply thank you all for coming to this event. And I would like for one more time congratulate the organizing committee and particularly our president, Alexandra Popovac. Yeah. For the amenities, for the scientific program, for the social program, but mainly for the warm hospitality. And because this is the area of the world that has people who are very warm, very polite, and very friendly. I'm Greek, that's why I'm saying that. Okay. Thank you very much. Alexandra, this is for you.
Thank you all again. And with this, we are closing this year's annual Congress of European College of Gerodontology. See you. Just a second, sorry, for the ECG members, we are gathering on the third floor in this building, meeting room, and at the third floor. We are going together now.